So now I'd like to introduce Richard Reilly, who's the Professor of Biomedical Engineering in Trinity College, Dublin. He's going to give a talk on the role of sensory information in the pathophysiology of dystonia. So hopefully now you'll all learn a lot about this today, and I'm sure you will, because Richard is an expert in this area, and this is his area of research. So my name is Mary Sharp. I am a member of the Biomedical Engineering Division in Engineers Ireland. So I now hand you over to Richard. Thank you, Richard.
Great. Thank you very much, Mary. It's very exciting to be here today to speak about some of the areas that we've been working on. And also I'd like to say thank you to Mary, who's just finishing up as chairperson of the Biomedical Engineering Division, and to congratulate John McGivney, who's going to be taking over as the new chairperson. John and myself go back many years on the Biomedical Division, so it's great to be working with him again. Today, I want to talk about some of our work that we do in Trinity in neural engineering within the Trinity Centre for Biomedical Engineering, particularly looking at sensory and cognitive processing. My lab looks at sensory and cognitive processing in a number of different areas, and it's been very exciting to work with clinical colleagues across the city in different departments of neurology and neurophysiology on different aspects associated with cognitive and sensory processing. For example, in Beaumont Hospital, we work with colleagues looking at bilateral cochlear implants and unilateral cochlear implants, looking at sensory and cognitive processing in those users. We also work with colleagues in St. James's and Tala University Hospital, looking at speech and gait as a window into cognitive function. And also with colleagues in St. James's and in the Dublin Neurological Institute at the Mater Hospital, looking at sensory and cognitive processing associated with neurodevelopmental disorders. But today I wanted to talk about some of the work that we do in sensory cognitive processing in movement disorders, particularly work that we carry out with colleagues in St. Vincent's Hospital, the Mater, the Dublin Neurological Institute at the Mater, and also with colleagues in Tala University Hospital. So when we think of human movement, we often associate it with, of course, the musculoskeletal system, but it's also, of course, very much driven and controlled by neural processes within our brain. And any breakdown that we might have in these neural processes ends up in abnormal movement. So we need to be conscious of, when we're dealing with movement disorders, that it's a neurological condition as well as a musculoskeletal system. And when we look at movement disorders and we look at neural functioning, there's been a lot of interest over the years looking at sensory aspects associated with movement disorders. This is a paper that was published in The Lancet a couple of years ago, particularly led by Mark Hallett in the NIH in the US, looking at how different movement disorders, Parkinson's disease, essential tremor, dystonia, for example, all have some aspect of sensory abnormality. So there's been a call for the last number of years looking at understanding that a little bit more. How do we understand sensory abnormalities in different movement disorders? And the area that we've been particularly interested in is one particular condition, which may be new to many of you, the area of dystonia. So dystonia was first clinically described by this gentleman here, Oppenheim, just over 110 years ago in 1911. Name comes from dys, meaning abnormal, and tonia meaning muscle tone. So this is where we get the name dystonia from. It's often characterized by involuntary muscle contractions and spasm. And what's particularly interesting here, and particularly around Oppenheim's observations at the time, was that he first noticed it in a cohort of young children. And what was interesting about that was that they were all from an Ashkenazi Jewish descent. So there was great interest at the time being able to look at dystonia possibly having some genetic origins. So just looking more broadly, when we think of movement disorders, we often associate Parkinson's disease and essential tremor, and dystonia comes in as the most common, third most common movement disorder, characterized by twisting movements, different postures that one might have, causing of different pain and discomfort associated with that. Typical onset for adult onset dystonia typically is after the age of 30. The prevalence is of a rare disease, so it's approximately 18 per 100,000, and we have approximately 700 people in Ireland which are suffering from dystonia. And that number is based on epidemiological studies that have been carried out in Europe, and also from figures from Dystonia Ireland, which is the patient representing association in Ireland. The average age of Irish patients tends to be around 65, and we see more women than men with this condition at younger ages, and then in older ages it tends to be 4:1 females to males. What's particularly tragic is that up until almost the 1980s, many individuals with dystonia were classified as suffering from psychiatric problems rather than a neurological condition. And many of these individuals were institutionalized, which is a particularly dark moment when we look back on recent histories. There are different forms or phenotypes of dystonia. Cervical dystonia is probably the most prevalent that we see in Ireland, and there's a picture of this kind of individual here with the very abnormal neck movements that we typically see. Writer's cramp is another phenotype of dystonia. Spasmodic dysphonia is associated with poor control of the vocal cords, and the singer Shania Twain has that particular condition. Blepharospasm, very disabling abilities inability to be able to control blinking while the head is moving, particularly disturbing and disabilitating. Also oromandibular dystonia, where the problems of the mouth opening continually also causes some challenges. And then there are task-specific dystonias. And one of these, which is particularly intriguing, is musician's dystonia. And musician dystonia has a devastating effect on professional musicians' career and their quality of life. And the Dystonia Foundation in the US estimates that there are approximately 2% of all professional musicians have musician's dystonia, and almost all of them are classically trained. So particularly interesting form of task-specific dystonia. While Oppenheim was first described it over 110 years ago or so, we also can see in different art forms that dystonia has been present for many centuries. So the top frieze here comes from a depiction that's in the Cathedral of Burgo del Sama, which is very near Zaragoza in Spain. And also we see down on the left-hand side an image which is a little bit more typical and more recent from Mogliani, describing a particular subject who has cervical dystonia, and also demonstrating a particular sensory trick of actually touching the chin, which seems to correct for abnormal posture. So this is called the gest-antagonist, and our understanding of why this sometimes corrects abnormal neck movement is not well known. So genetically, there has been great interest in being able to understand how dystonia comes about. We know that it has great impacts in terms of quality of life, but we really don't know the cause, and unfortunately there's no cure. So really trying to understand the pathophysiology and the mechanisms associated with this condition would really allow us to be able to develop new strategies of treatment. What's really interesting is that when patients first present to a neurologist with their condition, they often say that, no, there's nobody else in the family with this condition, I'm the only person. And then when they're pushed a little bit, it often comes out that so many of them have a relative who also has the condition in some form. So even though it appears to be sporadic, 25% of patients report that a family member is also affected. So we know that adult onset dystonia has what's called an autosomal dominant manner of inheritance. So that means that we only need to inherit the abnormal gene from one parent to inherit the disease. So this is particularly interesting, and there's been a lot of work, particularly looking at children in early onset dystonia, to try to understand some of the genetic mechanisms. And Laurie Yazelius, who's pictured here, who made a very important discovery while she was in Mount Sinai, she's now in the Mass General in Boston or Massachusetts, discovering that there was one specific gene, DYT1, which is associated with early onset dystonia. And this would have explained the problem or the observation that Oppenheim had in 1910 when he observed those children back in his clinic. So if there's a genetic predisposition to this condition, there's great interest in looking at genetic biomarkers for dystonia. And this has really caused scientific interest in research looking at the discovery and search for endophenotypes. An endophenotype is a subclinical marker of gene expression. And if we understood endophenotypes, then we may understand exactly how these diseases come about. So endophenotypes should be mechanisms which allow us to be able to understand the progression of the disease from a subclinical episode to manifestation in terms of a disorder. And if we can find an endophenotype, then it should follow certain types of criteria. It should be heritable. It should be associated with the cause rather than the effects of the disorder. It should be measured reliably and be specific to the illness of interest. And it should be one which varies continuously in the general population. So an ideal endophenotype for an autosomal dominant condition like dystonia would be present in 100% of patients, 50% of relatives, and not present at all in controls. So there's great interest in being able to look for endophenotypes, because if we could find an endophenotype, then we may understand what are the promoting or even the protecting factors which may be associated with this particular condition. So we can think of a mediational model of an endophenotype, as we can see on the graphic here, that goes from the gene all the way through the subclinical endophenotype, and then finally manifesting as the phenotype of the condition at the other end. So if we have the endophenotype, then the question one becomes of trying to understand or find the promoting or protective factors which are influencing the transition from the subclinical marker to the phenotype. So this would allow us to be able to understand questions such as, why do some individuals get dystonia, but their siblings don't, for example? So we've been looking for endophenotypes, and one of the first clues that we were trying to look at were sensory abnormalities in this condition. We know from many different studies, particularly studies in the literature which have used transcranial magnetic stimulation to show that there is sensory integration problems associated with the cortex, the outer areas of the brain of dystonic patients. But probably the most common hypothesis at the moment is there is an abnormal sensory integration involving the basal ganglia at the base of the brain. So we've been testing patients in Dublin, looking at different forms of sensory abnormalities. And one of the tests that we do is a very simple test. It focuses on spatial discrimination. We present a series of small plastic probes to the fingertips of individuals. And while they're looking away, we ask them to be able to rate the grating associated with these plastic probes. Is the grating a narrow grating? Oops. Is it a medium grating? Or is it a wide grating? And what we found was that control subjects did very well on this test. Dystonic patients did relatively poorly on this test, but rather spread out, as we can see from this graph here. So the y-axis here is the Z-score. And we've defined 2.5 standard deviations or 2.5 Z-scores as the normal range for controlled subjects. So we can see that our dystonic patients some of them are falling outside this range. And when we look at their children and we look at their brothers and sisters, we see also that some of them do poorly on this test. In fact, 25% of patients do poorly and 23% of relatives do poorly. So it doesn't really follow the ideal model of an endophenotype that we should have for an autosomal disorder such as dystonia. But what we did do with the same subjects, we were able to bring them into the MRI scanner and we're able to look at different areas of their brains, particularly looking at the structure of different areas of the brains, particularly in their deep part of the brain. And what we found was that there was increased volume in one particular area called the putamen in both patients compared to controls. So this area of the brain called the putamen had an enlarged volume, and we reported this a couple of years ago, and others have subsequently reported the same area as being overlarged or increased in volume in patients. So we were great interest in understanding what could the putamen be doing? Why was it enlarged in these particular patients? What could be responsible here? And would it be a useful endophenotype for dystonia? Just to be able to orientate you to the areas of the brain that we're actually talking about, here is the basal ganglia. So this is the kind of purple mauve area that's colored here on the graphic. We see the thalamus just beside it. And we also see the amygdala, which is also connected to the basal ganglia. And we see the putamen, which is this area over here. So it's the back area of and the top area of the basal ganglia. So it's this area that tends to be enlarged in volume in patients compared to controls. And it was around the time that we published this study that another study was published in the journal Neuroimage from colleagues in London, led by Maria Pastor, who's now at the University of Madrid, looking at an increase in activity in the putamen associated with temporal discrimination. We've been looking at spatial discrimination, looking at these plastic probes on the fingertips, but Maria Pastor's study showed that temporal discrimination could also influence activity in the putamen. In her experiment, what she was able to do within an MRI scanner was provide tactile stimulation to the forearm and also provide auditory clicks to the ears. And she asked subjects, and these were healthy control subjects, to be able to differentiate to see if they were listening to one single stimuli or two separate stimuli in time. So two separate stimuli with the interstimulus interval. And what she found was that the putamen was very much involved in being able to assist in temporal discrimination. So the outcome from this experiment that she reported on was that the putamen could be, in some way, the automatic perception and processing of temporal features, which could be very interesting to be able to look at in dystonia. So this was something that we were very keen to follow up the same procedure and look at our dystonia patients to see if temporal discrimination could be an interesting endophenotype. And that's something that we were able to look at. We looked at seeing if we could look at temporal discrimination. And temporal discrimination is defined as the shortest time interval at which an individual can perceive two sequential stimuli as asynchronous. So they could be visual stimuli, they could be auditory stimuli, they could be tactile stimuli. Are the two stimuli coming in a synchronous way, or are they asynchronous? So hopefully on the slide here, you can see a little graphic describing the visual temporal discrimination test. And the test is really to see, can you recognize when the two flashes that are coming up on the screen are distinct in time, are asynchronous, or are they still appearing synchronous to you? So hopefully most of you will see now in this little animation that they're coming in asynchronously. And what's really interesting here is that for younger subjects, healthy control subjects under the age of 35, we'll notice if there's a difference of about 25 milliseconds between the stimuli, we'll recognize those as two separate stimuli in visual stimuli that are coming towards us or auditory stimuli that's presented to us. As we get a little bit older, it tends to get a bit longer. But this temporal discrimination test reportedly is really interesting in patients with dystonia. So here we see the same type of graphs. We're looking at Z-scores here, and we're defining 2.5 Z-scores as the cutoff for normal temporal discrimination. And we can see that control subjects are all bunched around the mean here, but patients, 86% of them, have great difficulty being able to do this particular test. And in fact, 8.86% of them have abnormal TDT. And when we look at their relatives, both siblings as well as children, we also see that they do very poorly on this particular test. So we published this in the big journal Brain a number of years ago, and since then we've increased the numbers, and we're getting close to the ideal model of an endophenotype for an autosomal dominant condition, whereby it is abnormal in 100% of patients, 50% of relatives, and isn't present in controls. So we're almost there. We're about 90% at the moment in the subjects that we've been testing over the last number of years. So it looks like temporal discrimination could be this endophenotype that we've been looking for this particular condition. How do we measure endophenotypes? How do we measure temporal discrimination? Well, the visual test is probably the easiest one to describe. We present a set of stimuli, usually two LEDs in front of the subject, and we separate them by a number of degrees, 7 degrees to the right-hand side, 7 degrees to the left-hand side of a normal line in front of the subject. And the main reason for doing that is to stimulate in peripheral vision, because we're much more sensitive to changes in luminance in our peripheral vision. We carry out the test in a dimly lit room, and we ask them to see if they see asynchronous stimuli coming in on the left-hand side, or do they see synchronous stimuli coming in on the left-hand side? And we try the right-hand side, and we carry out an averaging of left and right sides. What's particularly interesting, of course, nowadays in outpatients departments and clinics, it's particularly difficult to find dimly lit rooms. So we ended up developing a 3D printed headset, which effectively brought the dimly lit room to the subject. And we can see a kind of a exploded diagram of that headset here. And we can see the subject using it here in this particular graphic. So what we see here is the subject carrying out the TDT test and the experimenter on the right-hand side taking a note if the subject is seeing the stimuli in a synchronous fashion or are they seeing two separate or asynchronous stimuli. We wrote a paper for the Journal of Visualized Experiments, and associated with that paper is a video. It's a 10-minute video describing how we carry out the TDT test and also how we carry out the analysis of the data that we get from this particular test also. And at the moment, one of our biomedical engineering researchers in the Masters of Biomedical Engineering at Trinity, Colin Coffey, is developing a TDT app that we can use with a low-cost VR headset to be able to develop the visual, auditory, and tactile TDT to be able to expand this to larger populations. In terms of the analysis, what's interesting here is that we acquired the data, and also then we subjected to two different forms of analysis to be able to get two different metrics. First metric is the point of subjective equality. This is the point where participants are equally likely to respond that the two stimuli are synchronous or asynchronous in time. We also then take the standard deviation, which is a just noticeable difference. And this is how sensitive participants are to changes in temporal asynchrony around the point of subjective equality. So we can see that here. This is participant 1, participant 2. Both of them have a TDT score, a raw TDT score of 65 milliseconds. And that's represented by this graph over here. And we can see also, we can generate the PSE, the point of subjective equality, and we can generate the just noticeable difference. And we can represent the data from those subject 1 and subject 2 on these graphs here. And what you can see by this profile, because we're fitting a set of cumulative Gaussians to their particular data, and from that we're generating the mean and standard deviation to be able to calculate the point of subjective equality and just noticeable difference, is that participant 1 is much more sure of when they're visualizing synchronous data compared to when they're seeing asynchronous data. We can see that by the slope as they're going from synchronous to asynchronous. Whereas participant 2, a little less sure. And we can see that the slope here is definitely different than participant 1. So we know that the precision associated with participant 1 is a lot greater than the participant 2. So being able to extract out different measures, not just the temporal discrimination score, but also the point of subjective equality and also the just noticeable difference, gives us the ability to be able to look deeper and to be able to compare different groups and different participants and within group differences associated with these measures also. We're also able to do neuroimaging, of course, and we can use the temporal discrimination score as a way to be able to guide different groups to different types of imaging. The putamen, of course, has been a great interest of ours to being able to understand why that's abnormal in volume from a structural point of view in patients compared to controls. But when we looked at temporal discrimination and we looked at relatives, so these are relatives of patients who didn't have dystonia, we found that their putamen volume was also increased. So now we're having a situation whereby temporal discrimination allows us to be able to separate relatives who seem to be abnormal in some way in terms of brain structure, but don't have the condition. So it might be able to explain some of the origins and pathophysiology of this particular condition. We also did functional imaging on these subjects as well, and we found that unaffected first-degree relatives had reduced activation in the putamen, even though the putamen was physically greater in volume. So we're seeing a reduced activation, but we're seeing increased volume. So in relatives who are unaffected, and we're classifying those relatives unaffected by their ability not to have dystonia, but also by their score they're getting on the temporal discrimination test. So there's something about temporal discrimination which seems the ability to be able to differentiate between the condition, so it's a good endophenotype, but also it seems to be present before you're manifesting that condition. So it looks like this could be a very good endophenotype. Of course, we wanted to be able to see what does it hold, how does it hold over the different phenotypes associated with dystonia. We looked at Reiter's cramp, We looked at cervical dystonia, spasmodic dystonia, blepharospasm, and we found that indeed over 85% of those patients did poorly on the temporal discrimination test. So very interesting. So why is this important though? It may be an interesting result, but what's so important about this? Well, it allows us to be able to look in families for promoting and protecting factors for this particular condition. So it allows us to do what's called linkage analysis. So here is one particular family, father and mother, and they went on to have 6 children, and these children are represented here. And those children themselves went on to have their own children, and you see those represented here. So the original parents have 26 grandchildren that are represented here. And what these numbers represent here are the temporal discrimination test scores, the TDT scores. And what we can see is a number that's greater than 2.5 is tended to be abnormal. And also the shading represents which people have dystonia and which people don't have dystonia. So this particular individual here has a temporal discrimination score, TDT score of 7.1, and has a clinical diagnosis of dystonia. Their parent, their father, doesn't, but has a very abnormal TDT score. So this parent must be the carrier for this particular gene, which they're passing on to their child. This parent over here has an abnormal TDT score of 6.4, has clinically diagnosed dystonia, and has passed it on, that particular gene, to this child who also just under the 2.5 score, but has a clinical definition of dystonia. So it allows us to be able to look in families to see what could be promoting and what could be protecting factors in different ways. So the evidence is good that the temporal discrimination score is an endophenotype for dystonia. It allows us to be able to look at both children and relatives of patients to be able to understand some of the conditions might be around this condition, the promoting and protecting factors, which is great. It seems to be very sensitive across different phenotypes of dystonia, which is also important. It's not affected by deep brain stimulation or botulinum toxin therapy, which are some of the therapies that are applied to dystonia to manifest and improve some of the symptoms. Doesn't cure dystonia, just manifests and offset some of the symptoms. TDT is not affected by deep brain stimulation, so we're obviously dealing with a different circuit within the brain in that way. So very interesting that this could be a useful endophenotype, and we wanted to know a little bit more about this. We carried out a big study a couple of years ago to seeing how does the TDT score vary across the population. And we looked at a very large number of women and men across different ages, 88 women and 87 men from a young age all the way to older ages. And we found a very interesting graph, which showed us that younger women have a much faster TDT score than younger men. And that after the age of around 40, there seems to be a switch, that older women tend to have poor temporal discrimination compared to older men. So there seems to be some advantage of age in women, which allows them to have faster temporal discrimination compared to men. So this is very interesting. This is very exciting to be able to understand why there would be this difference that happens to be present. And of course, it's critically important for a number of reasons. One, it's clinical research trying to understand disordered midbrain functioning around the basal ganglia disorder. That would be useful to understand that with temporal discrimination, but also to be able to understand some of the biology in this sexual dimorphism. Could it be genetic, or is it some way related to hormonal activity? So we've just recently published this year a viewpoint paper in the journal Movement Disorders talking about sexual dimorphism in dystonia and trying to call others to be able to look with greater detail at this particular issue. Of course, we often need to ask ourselves, why do we need fast temporal discrimination anyway? And hopefully this video plays well for you over Zoom. And as we can see, it's critically important. It's critically important for survival, not only in the animal kingdom, but of course in our own world also. And the advantage is that it relies on being able to detect fast looming objects that might be in our environment. And this is important, and this is an evolutionary advantage that we have for many, many years. We have different circuits that exist within the brain that allow us to be able to detect different objects rapidly, to be able to detect prey or to avoid a predator. This is critically important. And the fundamental aspect here is to compare and relate sensory inputs with motor outputs. And this action outcome pair is critically important to allow us to be able to carry out this type of fast detection. So the question that may be asked is, why is temporal discrimination so important? And hopefully from a survival point of view, we see that. What then does it mean for abnormal temporal discrimination? And what does it mean for abnormal temporal discrimination in relatives who may not have clinically diagnosed dystonia, but poor temporal discrimination scores? What impact does it have for them? So we need to kind of look a little bit further into some of the biology that may be associated with this. So the superior colliculus in the brain is a very important structure along with the basal ganglia. They are what are called phylogenetically ancient systems, which are highly conserved in structures throughout the vertebrate evolution system. And in mammals, they perform a very important function in the midbrain to be able to detect looming stimuli. So going back to our TDD test, for example, what could be happening is that we see a flashing light. The information goes directly from the retina straight to the superior colliculus. And then from the superior colliculus, it gets transferred to other structures in the thalamus and also to the substantia nigra pars compacta. So it splits out into other circuits after passing first through the superior colliculus. So you may not have heard of this particular structure before, but it's actually critically important. It's a hub for detecting approaching and looming objects. And within the brain, you can see that here, it's just the top of the midbrain, and the Latin name or upper hills gives away some of its structure and its function. You can see the physical shape that it has here at the top of the midbrain. And it's important for taking sensory information in and relaying it on to other structures within the brain. So what impact does it have when we're dealing with temporal discrimination and if we're dealing with dystonia? Well, we do know that different layers within the superior colliculus have different function. We do know that the superior colliculus contains sensitive neurons for being able to detect different types of stimuli. We do know that the superficial layers have direct connections between the retina. So they're taking retinal information directly in, which is important. And then the deeper layers of the superior colliculus project and activate brainstem centers, which generate saccades, and also project down to cervical areas in the neck, which orientate our head to face the target that we're looking at. So the superior colliculus therefore forms the location of a looming object in space and helps then in the orienting of movement of the head and neck to be able to face that particular object. So it doesn't need to go to higher levels of the brain to do that processing. It's an instinct that we have to be able to look directly at some target that's coming at us from behind or in our peripheral vision. And what's really interesting here, of course, is that these behaviors are modified by neurotransmitters, which are in and around the superior colliculus. One of those, which is very important, is GABA. So the neurotransmitter GABA has an important role here in being able to allow the superior colliculus to function. It has an inhibitory role, so it allows us to be able to turn on very quickly and turn off very quickly. The different layers, the superior layers and the deeper layers of the superior colliculus to be able to attend to different objects. And we do know that if there's poor GABA function, so that there's some form of disinhibition of GABA in the region in and around the superior colliculus, that would cause some problems. It would cause problems associated with the visual sensory neurons, and as a result, that may explain poor temporal discrimination. And also, if we have disinhibition of the motor neurons in the deeper layers, that may explain some of the abnormal movements associated with cervical dystonia, these abnormal neck movements that we see. In fact, there's been some evidence in the literature that talks about animal models and abnormal movements associated with disruption of inhibitory control of GABA in and around the superior colliculus. And just a few months ago, there was a paper in Communications Biology, which talked about inhibitory neurons in the superior colliculus mediating spatial oriented movement. So the superior colliculus seems to be critically important in this particular role, and critically important also in our temporal discrimination task. So why is it so important? It's important because in our test, our visual test particularly, what we're doing is we're having our light, an LED light, which is turning on and turning off. And in a normal healthy superior colliculus, we have different cells which are responding to that change in environment. And they're bursting very quickly, and then they're turning off and getting repolarized and ready again to fire again when there's a change in the environment. So when the LED is turning off, for example, they're continuing to fire. If we have the superior colliculus with reduced GABA inhibition, the impact here is that we get prolonged bursting or prolonged firing. So we don't have an inhibitory activity. We don't have shutting down and stopping the activity from taking place. We get prolonged bursting of those particular neurons in the superior colliculus. So when the flash turns on and when the flash turns off, we've got longer activity of those particular neurons. And of course, if we're trying to carry out our TDT test, where we're trying to look at deciding if the two stimuli are synchronous in time or asynchronous in time, then things become really difficult as a result of poor GABA in this particular area. So our normal superior colliculus will turn on and turn off when the stimuli are applied. There'll be a minimum distance, of course, in interstimulus influence, a minimal amount of time before we can differentiate to say, yes, there is definitely two stimuli here. I'm not just seeing one visual stimuli being presented. But if we have the superior colliculus with reduced GABA inhibition, this prolonged firing that we're seeing when, for example, the first flash occurs and when the flash is turned off, overlaps then with the second flash and the firing that we actually don't see that. We miss it completely. So the big problem for us and the impact here is that the ability to have reduced GABA inhibition could explain why some individuals are doing poorly on the temporal discrimination test, the TDT test associated that we've been talking about. We managed to carry out imaging of individuals in their superior colliculus. We can do that functionally. There's been a number of tests reported in the literature which target the superior colliculus, particularly those associated with looming visual stimuli that you see on the video, and receding visual stimuli and random stimuli. And we carried out a very large test looking at 64 individuals, all age and sex matched, 16 cervical dystonia patients who had abnormal TDT, of course, 16 relatives who didn't have dystonia but had abnormal TDT scores, 16 relatives with normal TDT scores, and 16 healthy controls. And we wanted to be able to see what's the difference in superior collicular activity associated with these four groups. And in the interest of time, I'll just cut to the chase and show the results. We found that there was disrupted activity in the superior colliculus with those with poor temporal discrimination tests. That means the patients and also the unaffected relatives. So there seems to be altered sensory processing in the superior colliculus, which could explain the association with dystonia and why they're doing poorly on this TDT test. So maybe disinhibition of GABA in and around the superior colliculus could be the basis of this. And we've been publishing the last number of years in different journals discussing abnormal temporal discrimination in unaffected relatives and patients associated with the superior colliculus and trying to expand on these areas. So in summary, we're showing that abnormal TDT suggests possibly a very good endophenotype for dystonia. There seems to be abnormal temperature discrimination, which is able to show difficulties in sensory processing in subcortical loops around the basal ganglia, particularly associated with the superior colliculus. We can carry out neuroimaging studies and psychophysics studies associated with the TDT to be able to understand some of the structure and function and pathophysiology of this condition, which is terrific. So it hopefully will allow us to be able to understand some of the mechanisms of this particular condition. The current experiments that we're looking at the moment are also neuroimaging and electrophysiologically based. We're trying to start a study looking at MR spectroscopy, which would allow us to be able to understand GABA inhibition levels at the superior colliculus, which would give us a different measure associated that we've seen before in both structure and functional imaging, a different measure to be able to see different changes in GABA levels and associated with TDT scores, which also might help elucidate what's going on in this particular region. And we also want to investigate other networks that the superior colliculus is connected to. One of the areas that is got a lot of attention in recent years is that dystonia is not just a movement disorder, but it's a syndrome. A syndrome meaning that it has many symptoms which are correlated together and associated with the movement disorder. So people talk about disordered sensory processing that we've overviewed a little bit today, neuropsychiatric challenges, sleep disturbances, for example. So we should really be talking about a syndrome of dystonia, not just the movement disorder itself. And what we've been arguing, and we published on this a few years ago, that really should be thinking about a pre-motor syndrome. Maybe some of these problems associated with sleep, with sensory processing, precede many years the movement disorder. And they also may be present in relatives of patients at the moment. And maybe there are ways to be able to study the promoting and protecting factors associated with this particular condition. So we know already that disordered processing in the superior colliculus affects temporal discrimination, and we can see that that's very much present in adult onset dystonia and in some unaffected relatives. But we also know that the superior colliculus is connected to other networks. And we've been, of recent months, we've been very interested in studying particularly the networks associated with the amygdala and the pulvinar network. So looking at the collicular pulvinar amygdala network and what impact it may have in dystonia. And we just published a paper earlier this year, and it just came out online actually last Friday in the journal Cortex, explaining this particular network and why it could be important. Why it's important is that the amygdala and the pulvinar network are critically important in social cognition. Critically important, obviously, in mood and anxiety. We associate that with the amygdala. So what effect could this be having on patients, but also unaffected relatives associated with this condition? So we're interested in looking, and we're currently doing that at the moment. Shamir Rafi and Rosalie Herrings, Mariali and Robbie Kelleher within Trinity and St. Vincent's at the moment are looking at both EEG, ERP-based studies and also fMRI-based studies to be able to look at this particular network, particularly looking at social cognition measures and measuring then electrophysiology and neuroimaging, particularly functional imaging associated with this networks to understand a little bit more what's going on. And finally, of course, we need to be able to look longitudinally at patients as well, to be able to look at motion, to look at genetics, to look at neuroimaging, to look at social cognition, and to study over years to be able to see what are the promoting and protecting factors associated with this rare condition. That will be critically important to do, and something that we and others are very keen to do. And we published earlier this month a very large paper, review paper, in Frontiers Neurology with many colleagues in Europe, describing some of the work that we're doing from a research point of view, but also in terms of a management point of view with patients in the area of dystonia, moving it from maybe a rare disease to be able to look at it in a more general framework and how we can collectively work together to be able to understand this condition and look hopefully for treatments in the future. Whoops. So hopefully that short overview today has given you some understanding of sensory abnormalities in movement disorders. It's sometimes too easy to think of Parkinson's disease or dystonia or essential tremor just in terms of motor deficits, but really sensory and perceptual impairments really underlie these particular problems. And biomedical engineering has a huge role to play in helping us understand these conditions and hopefully then come up with cures and treatments that will be effective in the future, once we understand the pathophysiology and understand the origins of these conditions in the first place. Of course, all of the work that I presented in the papers that we've published has all been due to the huge number of contributors, MD students, PhD students, and master's students in the lab over the last number of years have been very exciting and been terrific to work with these individuals. And I've also very privileged to have a great number of people in the lab now who are looking at this area of dystonia, but also other aspects that I mentioned before in sensory and cognitive processing. And particularly, I'd like to thank out my clinical colleagues, Professor Michael Hutchinson and Shona Reardon in St. Vincent's, and Professor Tim Lynch in the Mater, Michael Farrell in Beaumont and RCSI, and colleagues in Germany and the States. It's been terrific to work with them as a biomedical engineer to be able to help understand some of the electrophysiology and neuroimaging data, which can help understand conditions such as dystonia, as we've talked about today. So I'll leave it there, and I'm very happy to take any questions from the audience, and happy afterwards also to answer any questions by email. I'll leave my email on the screen here for people to take note.
Thank you very much, Richard. That was very interesting indeed. And if anybody has questions, can they put them into the Q&A and we'll pose them to Richard. I'm just going to ask one question. You mentioned musicians. Now, musicians to me is a very broad area because you've got composers and then you've got performers in everything from piano to violins to guitars, etc., etc. So is it a kind of a widespread in all areas of music?
Well, particularly in performing musicians, particularly in those who are playing instruments. And it doesn't seem to matter whether you're playing a keyboard or a string instrument, it tends to be possibly there across all musicians. What's interesting is that we were trying to use our temporal discrimination measures in musicians. And of course, musicians by their very nature, particularly professional musicians, are very well tuned to timings. So if we're using auditory discrimination or visual discrimination, they tend to be particularly sensitive to be able to pick up slight changes, given their professional practice in this particular area. So we've been working with the Royal Irish Academy of Music in Western Row to be able to study musicians and to be able to use temporal discrimination to see which musicians may be at risk of developing dystonia, musician dystonia later in life. They may have a genetic predisposition to having this condition, and then possibly through over practice or poor practice, they're developing this particular condition. So there's great interest to understand musician dystonia if it's due to poor performance or overperformance. And we've been trying with colleagues both in New York and Boston, as well as Dublin, trying to understand this particular phenomenon. So I think to answer your question, it's across all musicians, really. They tend to be particularly excited and interested about sensitive changes in sound and vision. And of course, our temporal discrimination test is based on the general population. So we had to be able to build a population of healthy musicians to be able to look at being able to test temporal discrimination in professional musicians.
Thank you. I have a question from Brian McCormick. Are there general applications of TDT outside of dystonia, for example, as a means to monitor cognitive issues as populations age?
I think there is. Certainly we do know that possibly not temporal discrimination, but certainly being able to judge different stimuli. We know sensory inputs are critically important to those associated with different forms of quality of life. We know that we need to take in visual information to be able to control movements in different ways. So those with poor multisensory integration in later life tend to be people associated with more falls and trips. So therefore, testing sensory integration in older people would be a great advantage to be able to spot people who may be at risk of falls or may be at risk of increased of tripping, and to be able to spot those people early and to come up with interventions which would prevent them falling over and causing damage.
Thank you. At the end there, you mentioned that hopefully you'll get a cure or something, but is there anything at the moment for these patients?
No, unfortunately. So really just to mask some of the symptoms, botulinum toxin injections are given sometimes into the muscles associated wherever the spasm happens to be to relax those muscles. But that's really a very temporary solution. It lasts for a number of weeks and patients will come back in to get injections every 6 weeks or so. Sometimes deep brain stimulation can be of benefit in certain number of patients. But again, that's trying to mask some of the symptoms as opposed to cure the particular problem in the first place.
You also showed a test where you had a 7-degree left and right.
Yes.
And you stimulated the left separate to the right. Do you stimulate both together at any stage, or would there be any advantage in that?
Not real advantage in that way. We're trying to look to see, are we trying in the left visual field or the right visual field, are you able to pick up these stimuli quickly? So we tend to present the stimuli only on the left-hand side or on the right-hand side, and then we merge those together, the data afterwards. So we take an average of the data in that way.
Right. Okay, we don't have any further questions unless anybody there has a further question to put into the chat, into the Q&A just before we finish. We have, oh yeah, sorry, there's one in the chat box as opposed to the Q&A. Very exciting research. How varied is this sensory data between dystonia participants, and how well do these results compare with clinical scales of severity?
Well, the problem is the clinical scales are very subjective. You need a trained neurologist to be able to recognize dystonia through a number of observations of movement and function. The TDT tends to be very sensitive across the different phenotypes of dystonias, which is critically important. So I think it has a huge role in being able to help in the diagnosis. One of the challenges in dystonia is that it's a rare disease, and particularly neurologists would be familiar with it, particularly those with movement disorder experience. But general practitioners probably haven't come across dystonia much in their clinical training. So for them to be able to recognize some of their patients who may be suffering from this particular condition and referring to a consultant neurologist who would have experience in this area, that tends not to happen very often. So what we try to hope to do is to try to promote the understanding of dystonia, and we try to do that with the Patient Association Dystonia Ireland, to be able to project and explain this particular condition to GPs. So as a result, people can get diagnosed and get diagnosed objectively as soon as possible.
Thank you. That question came from Aaron Yurkovich. And another one here from Maeve Smith. Brilliant talk, thank you. What is the biggest barrier to collaboration between university-based research and hospital-based clinics?
Probably the biggest barrier in the last number of years is probably the number of ethics and GDPR forms that we have to go through. Other than that, there hasn't been. It's been absolutely fantastic to be able to work with clinical colleagues. So obviously the normal, we have to go through ethics, that's very important. And we have to do that both in the hospital where we're recruiting patients, as well as within the university where we're carrying out the analysis of the data of those patients. That's normal. With GDPR, it tends to be more complex, so we have to fill out more forms for doing those kind of things. But once we're past that stage, the collaboration actually works very, very well. One thing that I tend to do is go to all of the clinical meetings associated with the different research groups that we're dealing with. And as a result, I understand the language and the vocabulary associated with those clinicians. And I think over the years that we've working together, they're understanding our vocabulary. So now we have very much shared interests of being able to be able to work together. In terms of publications, that's worked very well, that we have publications in clinical journals and publications in biomedical journals, and it's worked very well. One of the advantages is that I try to pair together MSc students and PhD students who are coming through neural engineering or biomedical engineering with those who are doing PhDs or MDs in the clinic. And that works very well. So they end up having two people working together, but from different aspects, looking at the same problem. And that has always worked particularly well. And it's the case that we have today in terms of dystonia. Many of the people I mentioned were teams working together to look at different aspects in different studies.
Thank you. As somebody who's involved in the ethics of all these things, I'm glad it doesn't stop you researching anyway.
No.
So I'd just like to now thank Richard again for his talk, and thank all of you for your questions and for your attendance. And there's lots of thank yous coming in from various people, Richard. So thank you very much indeed. And thank you all for attending this webinar.
Great. Thank you very much.
Bye, everybody.